Sir, Head of Department of ENT, Head and Executive Engineering Healthcare, who is known as 360-degree surgeon, a rare blend of surgical excellence, academic brilliance, and inspiring leadership. To formally comment the scientific gathering, we are now invite Dr. Annabelle D'Souza Seeker, our esteemed medical director and Group Head of Quality Services, to deliver the welcome address.
Good afternoon, everybody. So after this very heavy, wonderful lunch, you really want us to sit and listen to this ENT masterclass. And not only that, sir, you have brought two guest speakers all the way from Nagpur and Mumbai. And of course, it's really wonderful to have them with us for this masterclass. I think we all know that ENT department is very, very strong with their academic programs. In addition, of course, I know about the clinical excellence too. But I think this is the only department in our institution that really focuses on this series of master classes and with a national speaker program. I think this is a lesson I think we should tell the other departments also to do something like this, because it's very nice to get external perspectives and speakers of national repute with us to encourage our students also, as well as our clinicians. So welcome to you both, and I wish this masterclass a success. Thank you for having me.
Thank you, ma'am, for the gracious opening. Now, to illuminate the path ahead and introduce our distinguished guest speakers, and privileged to welcome Sanjeev Mohanty, sir, to come up to the dais and initiate the proceedings of today's program. Over to you, sir.
Good afternoon, all. After a sumptuous lunch, hopefully we'll get really something different in the perspective of clinical practice, that we always look at only the surgical aspects. Also, specifically for ENT head and neck, we think about either the temporal bone or the fess and all that. But slightly neglected zone allergy, which almost all general practitioners, ENT surgeons, and everybody they face in day-to-day life, but they're probably little bewildered as to what to do next when they keep coming back to you for reviews and you don't know what to do next. To envisage that and shine on this slightly, I won't say neglected, a niche topic which we haven't known much of late. It's really developed a lot, and we've got two very talented, very should I say engrossed speakers who are well knowledgeable, and they've done with a passion. I'll just introduce both of them very briefly. I know them personally also, and for a long period of time. First, in that order, not in terms of reference, Dr. Rupali, who I know first as a medical legal expert, then as a very avid cyclist, a good singer, a dancer, and now as an allergologist, specifically with regards to ENT. And I think if I missed out anything, I don't know much, but I think with the little interactions I've had, welcome, Rupali. I know you've taken a lot of meandering flights in between the missiles here and there to come and reach on time. Thank you very much for gracing this occasion. I request Dr. Sudha to just welcome formally Dr. Rupali from. So this for the photo op, it would be nice to have one. That is playing Coco now. Yeah, okay. Yeah. So we'll listen to you more when you start talking. And the next speaker, again from Mumbai, is Dr. Sunita. Again, very dear friend who bloomed as an ENT surgeon in the Port Trust Hospital in Mumbai. And then in fact, asked her what's the passion for allergy, and she's gone all over the world in Harvard and so many other places. She created a niche for herself in this very, very difficult topic, I would say. I mean, for any patient who comes to us, we just know a few sprays, some drugs, and they keep coming back to us. And she is again an expert, and she took the bull by the horns, and now she's carved a niche for herself, both nationally and internationally. And without her permission, I'm going to tell something else. You might feel proud, or maybe if you give me a little pat or pat in the back, I'm okay with that. Enormously transformation journey, and when I looked at her today, I thought, which college is she studying in? If I don't want to make any sense of purpose to tell that, without any drugs, without any bariatric surgery, she's lost only a small matter of 30 kgs in the last couple of years. And that's how you see her as lissom, as you can see her today. And I think she's got the maximum number of immunotherapy with biologics in the country now with regards to allergic rhinitis and related. I'm sure we'll be very much encouraged to know more about what she has to say. Sorry if it's given you a little round of applause probably for that, and request Dr. Ansia to just welcome her with a bouquet. And with this, probably I will hand over the stage to the next speaker or next in line of the program holds on. I'm sure it'll be an interesting one. So thank you very much for coming, both of you. In spite of the geopolitical scenario, I was myself a little disturbed on a personal front, but I wanted the show to go on. And that is something which I want to place on record. Thankful to all of them who have cooperated on time. Thank you so much.
Thank you, sir, for that warm introduction. We now move on to the scientific segment of today's program. To start with, I'll take the honor of inviting Dr. Roberta Patel to enlighten us on the topic allergic rhinitis, diagnosis, and management protocols. Over to you, ma'am.
Hello. This mic is on?
Okay, well,
Yeah.
then I think is to keep this on.
Okay. This is the mic.
Just keep it station.
I'll do. So I think this needs to be charged. The laptop needs to be charged. The charging.
Keep this mic. Stay still. Just stop.
Okay. The laptop needs to be charged. It's not charged.
Take it.
Just put the charge.
Yeah, do that.
Well, how will Thanks a lot, Dr. Sanjeev sir, for the kind introduction as well as inviting me here. So he has already told that I am a medical legal advisor first, and this recent interest in allergy. But I've been doing allergy since last 8 years, and I've seen that still there are a lot of misconceptions or myths regarding allergy. yesterday only, I'm quite active on social media. So yesterday on LinkedIn only, someone had posted a article on rhinitis because of the overuse of oxymetazoline or xylometazoline nasal drops. And one person, he wrote that I have been using it since long time because there is no treatment for allergies. When I checked that person's profile, I saw that he was a CEO of a very big like multinational company. I mean, such an educated person, if he doesn't know that there is still, I mean, there is a treatment for allergy. Now, me and Sunita, we have been practicing allergy since last 7 to 8 years. So then how will the another a common person will know that really there is a treatment for allergy? And so uh, we both are like, we are trying to propagate our knowledge. And so we feel that every ENT surgeon, not only ENT surgeon, a physician, a pediatrician, because an allergic rhinitis patient will go to a physician, to a pediatrician, to a chest physician, and to an ENT surgeon. One in four patients, they are suffering from allergies, any kind of allergy, and allergic rhinitis is the highest. And it can occur at any age as well. Though it is not a life-threatening disease, but we all know that quality of life is hampered. And nowadays, in such a competitive world, everyone wants a good quality of life. No one wants to hamper their studies, their work. Neither everyone wants a peaceful sleep. 40% of these allergic rhinitis patients, they suffer from asthma, and 80% of the asthmatic patients have allergic rhinitis. These are the comorbidities. The most common is the asthma, the nasal polyps, rhinosinusitis, otitis media, mouth breathing and sleep disturbances, and conjunctivitis. Now coming to I won't go in detail in of the pathophysiology, but there are two phases of any allergy, type 1 hypersensitivity. So during the first phase, when the person is first time exposed to any kind of allergen, what happens, this antigen, it gets spliced into fragments by the antigen presenting cells, and they get attached to the major histocompatibility complex. These epitopes, they will be then visible to the T lymphocytes, which will recognize them as foreign. Now, a response like class switching happens, which causes these T cells to produce interleukin 4 and interleukin 13, which then stimulate the B lymphocytes to produce the IgE antibodies. Now, these IgE antibodies, they are released into the blood as free IgE as well as bound IgE. This is important when we are doing the blood test or the other tests. Now, these mast cells, now they are ready to release the mediators when again these antigen present, again these IgE antibodies come in contact with the antigen. So the second phase is the re-exposure. That is the second time when the patient gets exposed to that allergen. Now this antigen will be picked by the specific IgE bodies on the surface of the mast cells, and the trigger, which it will result in the inflammatory release of the inflammatory mediators, and so the symptoms will occur. Now, what are the most common aeroallergens? House dust mites are present all over the world. They are more in the humid climate because the 80% of their body is made up of fluid. So they are more common in the humid environment. They are present in every home, and they are responsible for 80% of all the allergies. Second is the fungi. They are responsible for allergies. The third are the tree pollens. Now this pollen is the Holoptelia, which is more common in the western part of the country. And most of the patients, they are allergic to this Holoptelia. Then the pets like the cats and the dogs, which we all love. And the again common is the cockroach. We all know the symptoms according to the euphoria guidelines and the area guidelines. There should be 2 or more of the following symptoms. That is the runny nose, sneezing, nasal obstruction, nasal itch, and the ocular itch. Now the ARIA classification, again, when the allergic rhinitis has been classified, they have given importance to the quality of life. Now, if we see that in the mild, the quality of life is not disturbed, but in moderate and severe, the patient has sleep difficulties, limitation of his daily activities like sleep, sport, and leisure. There is impaired work or school, and the symptoms are quite troublesome. It is first the classification was like seasonal and perennial. Like the patient, some patient used to have seasonal complaints, some used to have perennial complaints. But now the classification has been changed to intermittent and persistent, where the symptoms are less than 4 days per week in intermittent and more than 4 days per week in persistent. Now the diagnostic modalities. When a patient of allergic rhinitis comes to you, we naturally we do the clinical examination. We all know there's a pale mucosa, mucoid discharge, and or the allergic salute. But the most important is the history. History, and history. That is the most important diagnostic modality in any patient of allergy. Now, what will you ask in the history? The most common is the family history. If a patient is, if one parent is suffering from any allergy, then the patient has 40% chances. And if both the parents, then almost 60 to 80% chances that the patient will be atopic. Then the second is what are the worst affected months? In which month the patient gets the most symptoms? Like I showed you holoptalia. If the patient is allergic to holoptalia, that means the patient, the pollination period of that, every plant will have a particular pollination period. So that in the holoptalia, it is February to April. So the patient will typically tell that in February, March and April, he has symptoms and the whole year is quite fine. Whether symptoms are perennial or whether seasonal, again, to differentiate between the pollens. Whether the patient is having symptoms either at his place of residence or a particular city. There are, some patients will tell that they are working in Mumbai, they don't have symptoms there, but when they come to their native place, they start having symptoms. Or some patients like who are working occupational, like who are working in the bakeries, or who are medical personnel who have latex allergy, so typically they will tell that when they go to their work, they start having symptoms. So again, the place of residence and the occupation is important. The dietary history is important in cases of urticaria. Medical history, there are a lot of disease like autoimmune diseases associated, which we have to ask. Medication history, if the patient is on any AC inhibitors or beta blockers, or there are to rule out even the drug history, again the medication history is very important. The ventilation of the house, again, as I told you, the humid, the environment, the fungi, the dust mites, they thrive in the humid environment. So the house has to have a good ventilation. The wet walls can be a reason for fungi. Pets in the house. Cat is one such pet. It's the allergen of the cat is very sticky allergen. So even if you have removed the cat from the house, the allergens will stay in the house even for 6 months. So the history of pets in the house is again very important. Now, what are the tests which we do? There are in vivo and the skin prick test and the nasal provocation. Nasal provocation is usually done for research purposes. In vitro, the serum specific IgE, total IgE, CRD, and the basophil activation test. Now, the skin prick test. The World Allergy Organization, the American Allergy Organization, European, everyone has said that the skin prick test is the gold standard test for diagnosis of allergies, especially the respiratory allergies. So now while doing skin priction of antigens, what antigens you are using? Already I told you you have to check for what the fungus, the tree pollens, the house dust mites, the pets, and the cockroaches. So pollens you will decide according to the pollens which are present in your region, because India is a big country, a different geographical location. The pollens which are present in Kashmir will definitely not be present in the south. So after consulting your aerobiologist, you have to know which pollens are present in your area. So your skin prick test, allergy test should have those pollens which are present. The house dust mites, there are 3 house dust mites present. Then as I've already told you, the cat and dog. Now coming to the positive and negative control, I'll tell you when I explain the test. Now factors which affect the skin prick test. The medications. You are going to check the IgE antibodies. So you have to stop some antihistaminic medications before doing the test. At least for 5 days before, you have to stop those medications. You have to stop beta blockers also. Coming to the age, if the patient is more than 60 years of age, the skin does not show good results. So its skin prick test should be avoided before after 60 years of age. The area of the body. Now, where will you do this skin prick test? It is the back or the forearm is preferred, and the distance between the test site should be at least 2 centimeters. Now, why do we do this test? We have to determine the presence of specific Ig antibodies on the surface of the mast cells, as I told you in the pathophysiology. And while doing, we see a wheal and flare reaction after that allergen is introduced into the skin. Now we are seeing the sensitization. We are not seeing the allergy. If you were after seeing the results, you are going to tell that the patient is sensitized to that test. He is not allergic to that test. I'll just explain the test. See, as I told you, the test, it can be done on the back or on the test can be done on the back or on the hand or the forearms. First, you have to clean the skin. After that, you have to check for the histamine and saline. The histamine, the saline, it should be, sorry, the histamine, it should be 3 millimeter more than the saline. So this histamine, it should be 3 millimeter more than the saline. So the saline we consider as the negative control, and the histamine we consider as the positive control. After that, these allergens, if the histamine is not more than 3 millimeter, that means the patient has taken some antihistaminics, and we should avoid doing the test. Then the allergens, they are placed as drops on the skin, and then we prick them with a lancet. After pricking, we see the results after 15 minutes. After 15 minutes, you will see such kind of results if the patient is sensitive to those allergens. Now here we are, as I told you, that we are seeing the sensitization. We are not seeing the allergy. The patient can be sensitized to a lot of allergens. As we have seen in this picture, the patient is sensitive to allergens. So you have to correlate it with the patient's history, which I told you that. So we are testing the sensitization. After correlating with the patient's history, then only you will come to know that the patient is allergic to that particular antigen. So the skin prick test is a rapid, safe, it's a cost effective, it's a clinically relevant. The patient himself can see those results on his skin. And it's a very simple method for detecting the allergic sensitization. And it's a quite highly sensitive and a specific test. It's contraindicated in pregnant women when the patient has severe lesions on the skin, because we won't be able to see the results. Even in dermatographism, same thing. The skin will be very sensitive. If the patient is suffering from any major illness, whether the patient is on beta blockers or AC inhibitors, and you should do a PFT or the spirometry. The peak flow, if it is less than 70%, then try avoid doing that test. Now coming to the in vitro test, the serum specific IgE. Initially, you must have seen ads in newspaper that do this test and you get your allergy tested. That is an obsolete method. That is the ELISA test which was done before. Now it's the serum specific IgE, or we call it the immunocap test. It is considered as the gold standard test in the in vitro test. Now this test, it provides an objective measurement of the circulating allergen specific IgEs. In skin prick test, we are testing the bound IgEs, and in serum specific IgE, we are testing the circulating specific IgEs. Higher the level of specific IgEs, the higher is the risk for the symptomatic allergy. The test report should always be interpreted with the clinical history of the patient, as we see even do in skin prick test. This is the difference. The skin prick test, we test the bound IgE. In serum specific IgE, the circulating IgE. It is less sensitive than the serum specific IG is less sensitive than the skin prick test. It's only done when the skin prick test is contraindicated. It has no interference with medication, but the cost is very high. Now coming to the challenges, even with these tests, sometimes we have challenges like the aeroallergens, they are present ubiquitously and which makes the allergen avoidance very difficult. Sometimes there is polysensitization, like saw in that picture, there were multiple sensitization. Either the allergens, they belong to the same or the different families. Then there is a possibility of cross reactivity. So the clinical decision becomes very difficult, or the allergen immunotherapy is not giving results. So in such cases, there is another test which is called as the component resolved diagnosis test. Now, what is a component resolved diagnostic? All the allergens or the living things which we can say that they are made up of millions of proteins. So now, suppose we are saying a cat. A cat is not a single protein. It contains multiple proteins. So for some allergies, there are multiple types of proteins which a person may be responding to. So now, for example, if in this picture I've shown a peanut will have ARA H1, 2, 3, 8, and 9. So these are the different protein components. Now the patient might be allergic only sensitive to only one or two uh, components, out of which the ARA H8 is quite I mean, it has a lot of chances of severe anaphylactic reaction. So the CRD test is done to find out which exact component the patient is sensitive to. Now coming to, if you're testing for a, if you're doing a skin prick test, the patient might be sensitive to a cockroach, the patient might be sensitive to a dust mite, as well as to a shrimp. All these have a common allergen that is the tropomycin. Now, in such cases, whether the patient should avoid shrimp or there is a cross reactivity, in such cases also the CRD test is quite useful. Now, coming to the house dust mite, how it is beneficial in house dust mite? The house dust mite of these following proteins: DERP1, DERP2, 5, 7, 10, 20, 21, and 23. So if you are giving, when you are doing the skin prick test, it will come as the sensitive test, or we can say the positive test. But the patient is not to immunotherapy because it might be chances that the positive protein is 5, 7, 10. So this, if the whatever immunotherapy, these allergens, these proteins cannot be extracted, so they are not there in the immunotherapy. So the patient who is positive to only DERP1 or 2 will be a good candidate for immunotherapy. However, the test is quite costly. This is the report, how the test report comes. But the test is quite costly, and so it becomes difficult to do it for every patient. Now coming to the management protocols for allergic rhinitis. The ARIA and the Euphoria, they have given certain guidelines. There are four main things, that is the allergen avoidance, the patient education, pharmacotherapy, and the immunotherapy. The most important, allergen avoidance. Now the patient, you know that the patient is allergic to, sensitive to house dust mite. So these are some of the allergen avoidance measures. As I told you that the house dust mite, it contains of 80% fluid, so it will survive in more in a humid environment. Now, for such things, you have to wash your pillow covers or beddings in a temperature of more than 55 degrees Celsius. Avoid using carpets and mattresses which will, harbor these house dust mites. Try to use a vacuum cleaner with HEPA filter. And you can even use allergen-proof bed covers and pillow covers.
patients, so that outcomes seem to be much better. So safety profile, they're pretty standpoint. Suppose you've done all that. You've got the pseudoephedrine, you got the fixofenadine, all varieties of antihistamines taken care of, those H1 receptor blockers. What do you do next? Lucast, you've taken the leukotriene receptor blocker, but then what next? So this is what I feel. If there is symptomatic relief is still questionable, then you have to have combined strategies. You start with the conservative mode, doesn't work out, go for the surgeries. And that too, these surgeries are not very, should I say, standardized, or it's not anybody can just perform the next day. You need to have a good insight into the anatomical attributes in that zone. And as Vijay said, sometimes you might mistake a vasomotor rhinitis for an allergic rhinitis, and that's why we get a problem. But I need to also tell this part that vasomotor rhinitis, one more point, it will never be bilateral all the time. You can have only unilateral. You'll be thinking whether it's a CSF rhinorrhea or whether it is something else. So when you have a conditioning effect of a patient who has a mixture of both, and you don't know the spectrum as to which one is the one which is actually taking care or manifesting clinically, then you have to think of the surgical aspect. Okay, I see a few other youngsters who have just trooped in correctly at the right time for them to know about the surgical aspects. Okay, so here what I've done is, what is my small experience or our team's small experience is, when a patient is coming for a long period and totally disgusted and disinterested in trying out further new brands of any antihistamine or for that matter steroids, that's where these are the two aspects that we can think of. One is a selectively posterior nasal nerve section along with VDN stimulator. That's a little extended format. So I'm going to just talk about a few which we've done recently. This is an edited video, so just for you all to be a little comfortable with what I'm trying to say. This is in the lateral wall of the nose. You do a middle metal antrostomy, posterior part of the the fontanelle. You can see a little bit of every time the postnasal nerve will be accompanied, any nerve will be accompanied by a small vessel. Once you see that, you will find out this is the area of the sphenopalatine foramen. It will be just below that. So in other words, for a surgical aspect, when people are interested, the posterior end of the inferior turbinate, which will correlate with the inferior part of the sphenopalatine foramen, just about 3 to 5 millimeters behind. That's where you get this nerve. And it has got two branches. It goes superiorly and inferiorly. Superiorly, it goes into the superior, the middle turbinate and the areas around. Inferior will go through this, the posterior part of the inferior turbinate, and maybe a twig finally gets into the lacrimal nerve. So again, anatomy, neurovascular anatomy, anywhere is important here, obviously. So that was on the right side. This is on the left side. Just did last week. Basically, for this workshop, I thought let's record that. So this is how sometimes it gets embedded in the flap. So when it comes out of the foramen, it gets embedded in the flap that you do, and you can call it neurectomy, neurolysis, anything. This is just an edited one just to tell you how it is. Now, if these postnasal nerve doesn't work, this is very efficacious. I've seen patients, they really get a lot of relief after that. How long? It is not like malignancy surveillance post-op that you keep on calling them and asking them for the analog scale. That's so nice. For the pain score, we can do it, but not with this. It will be very difficult. So next, what we do is, a patient who keeps on coming. I've just done about 7 video neurectomies in my life, and all of them, out of that, 3 of them were with vasomotor rhinitis. But when you have a conglomerate of a spectrum which has features of allergic rhinitis, I've been excessive sneezing, excessive watering, everywhere. I mean, they are totally catarrhal, so they don't know what to do next. And that is the time when you option. I consider the video neurectomy is almost akin to what we do for labyrinthectomy in minias. I would have seen some at least diagnosed with more than 100 minias, but I've just done 5 labyrinthectomies. I'm talking 3 canal. Single canal you can do, but only 5. So you can't be doing videonectomy for all patients. Just to show you, this is how to do it. Very, not simple, but anyway, this is a lateral skull base. You do an extended fess, get into the maxillary sinus, open up the sphenoid. There'll be 2 openings. The medial opening will be the medial inframedial opening is the canal where you have the uh, nerve. It will be there'll be 2 openings. One for the vidian. Again, it will be accompanied by a nerve and a vessel together. So you've got to be very, very clear. Identify the foramen. It goes straight, and finally it gets connected with the infraorbital. So V2 and this all together. It's just to show you it is not very difficult if you know the anatomy. They just have to identify the areas. I will just run it later. So what are the rest of the things? Now, this is about the causes. So you don't allow the parasympathetic activity which happens, or which is the ganglionic block that you do for the pterygopalatine ganglion. So the secretory fibers are cut. So secretory fibers cut means you do not have the gland to secrete. That is the reason why you get a little dry nose. So, but yes, out of the 7 that I've done, 3 of them came back with dry eye, and it was a little difficult for me to give them. I'd actually taken a counseling session for them even before the surgery that you might have a dry eye. So 3 of them had a dry eye. Slowly with the refresh drops and all, they got probably used to it. So these are all the pitfalls of such surgeries, a little advanced, a little more radical, which might compromise the normal refreshed, the uh, not only the vascularity, you'll have also the lubrication of the eyeball. So you have to take into account. So now coming to, this was the cause part of it. Now, what does it have an effect? So effect would be, as she initially told, boggy turbinates, pale mucosa. It's mechanically blocking the airway. This is nothing to do with physiology or altered physiology, which reverse it back to the normalcy. No, we are trying to get a mechanical, airway enlargement by addressing the effect of the allergic rhinitis or the allergy or anything. So these are huge number of procedures that you can do. I'm just going to, I think during the normal fest that you can do a little outfraction of the infraturbinate to open it up, but that's very temporary. Earlier people used to do cauterization. We all have done that, and it'll come back again. But the one time tester that that I have seen in my small practices, something like this. It's better to remove the bony portion of the inferior turbinate if you really want a very permanent one. And again, this was done last week, just for this, just wanted to tell. So you go there, just infiltrate, you take an incision anteriorly without disturbing the nasal valve area, which is the anterior part of the inferior turbinate, and the surrounding zone. So that gives a little bit of ball valve mechanism. So we go into that, remove the bony ledge of it, which is an erectile tissue which comes out, and then you put the flap back with a mucosal margin. So I like this because there's a special inferior turbinate wand, or rather, microdebrider. You just go in and have a look. Beautifully, it gets in, and I'm going lateral to the bony part, and I'm going medial to the bony part, mucosa being intact. Believe me, this is very good. Yes, it's a little costly, but you have only one small little prick anteriorly. You don't disturb the mucosa anywhere, and after some time, it's just like a normal septum flap back, and you find a very good effect. Again, keeping in mind that the anterior inferior part of the inferior turbinate is the important part of the nasal valve. Well, we have other modalities like you have the co-ablator, the laser, and all that. So many things you can do, but those are all mechanical. These are all with mucosa preservation techniques for allergic rhinitis, or rather, very infuriated, hypertrophied inferior turbinate. I think these are good methods. So the key takeaways for surgical management nothing is foolproof. So these are all the options that I'm talking about. You can do a postnasal neurectomy, which I've shown. Little refractory, you can go for endoscopic video neurectomy. They're all major surgeries. It can't be finished in just 10 minutes, 15 minutes. It takes time. And of course, nothing to do without a pharmacotherapy. So that was for surgery. For medical management, if you want short-term decongestion, long-term decongestion, probably you need to go for long-term steroids. And beyond that, probably Dr. Sunita will deal with the biologics that she's going to talk about. Thank you very much. Now, I would want questions from the experts. The rest of the questions, we can have it at a later date from the others, in case you have any with your small experience, with my small experience. Okay. You all are experts, so you don't need any questions from my side anyway. Thank you very much. I'm cutting short the question answer session. We'll have it after Sunita's talk, because I would want Rupali to be around when she's there. Don't worry, you will not miss your flight. Sure.
Thank you, sir, for sharing your knowledge with us. May I now request Dr. Jayaram, sir, Senior Consultant, Department of Pulmonology, to kindly facilitate Dr. Sanjeev Body, sir. Thank you, sir. Next, we are privileged to welcome Dr. Sunita Shukla to walk us through the topic, Practice Essentials in the Management of Recurrent Cytokine Polyposis and Recent Advances of Treatment.
Where is my slides? Where is my pen drive? No, he has already put it. It's here. Check this one out. Yeah. Yes, yes. Yes. Is this working? Let's start.
Hello.
Which mic I have to use? Hello, anyway. Good afternoon, everyone. I know it has been a heavy lunch for all of you. And I request the photographers, once you are done, then please leave us alone. We are here to teach. I will respect everyone to please concentrate. I have tried to make my talk very interesting and practical for a doctor as far as allergy is concerned. So I would just like to know how many of you are ENT? All are ENT here? Okay. Non-ENT? Just a show of hand, I'm not answering. Oh, very good. Okay. So my talk will be 80 to 90% ENT, but rest of it is very interesting as per the allergy aspects. So let us start. I am a ENT surgeon by heart, by hand, but now I'm totally into allergy practice and I am a pure allergist now. So this is the concept of whatever talk I take. I feel if I am able to tell you the practical aspect and we can bridge the gap between the latest recent updates, theoretical part into a practical thing, and you can take something from here and use it for the benefit of your patient, then the talk is successful. Allergies, as we all know, was actually a disease of the rich initially. It was never there before, but now allergies have risen in a large quantity, and now we see it even in the middle class and the lower class people. So actually, allergy is a systemic disease. It is not a local disease. When we see allergic rhinitis, it is the nose which has allergies, but you can have allergy in any part of the system. It could be allergic rhinitis, asthma, urticaria, food allergy, drug allergy, waxing allergy, and so on. It's a whole new world. So, as my colleague and friend Rupali was mentioning, allergic rhinitis, let us start with it because we are most of us here ENT surgeons. The first part of treating your allergic rhinitis is first a precision diagnosis of allergic rhinitis. How do we do it? It's with the help of a skin prick test. Once you know what are the allergens causing all the problem, you can go for a allergen avoidance method, so that you take care whether it is dust mite, pollen, pets, and so on. Once you have done that, you have to give good pharmacotherapy to the patient because the symptoms have to be cleared up. Whatever gyan you give to the patient, if the patient is not better symptomatically, he will not come back to you, and that's not a good thing in your practice. Then you have something called as a disease modulating treatment in allergic rhinitis, which is allergen immunotherapy. And with this, you stop the present allergy and you can also prevent new allergies coming up. That is neosensitization. Few important updates post COVID. Lot of new guidelines have come up in allergic rhinitis and the comorbidities. One of them is smell. Whenever we take a history, whether you are residents or you are consultant, smell is an important aspect. Why we will get to know in further slides. And you should understand the quality of life of the patient. Rupali was just mentioning there are two very good markers of quality of life. One is a SNOT 22 questionnaire, which is advised by EPOS 22, and the other one, which ARIA and Euphoria says as the visual analog score. So this thing is very practical for all of us, whether you're on a research institute, in your private practice, because it becomes very easy for you to question a patient of allergic rhinitis as per the symptoms. And this is important as per the recent ARIA guidelines also. That is how you will try to put your patient into a scenario and take a decision on the management part. So even if your patient is illiterate, you can easily ask your patient, are you in the green zone of mild allergic symptoms, or are you in the red zone where the allergy symptoms are severe? So that's the advantage of that. And most of the time, your allergic rhinitis patient will have multiple comorbidities. What these comorbidities will be? We all know that the nose continues down as the lungs. So allergic rhinitis very often will have allergic asthma also. If there is some pulmonologist here, as a doctor also, even if you are ENT, you have to know that uh, there is no wheeze without a sneeze. So you should always have your stetho. Any patient coming with allergic rhinitis, always put the stetho on the lungs and on the chest and see what is happening. Because there is a big taboo of asthma in India, and not only India, throughout the world. Once you start asking the patient, do you have asthma or dama? The patient, 90% of the time, they will never say, I have any issues. But if you just change your history, do you get shortness of breath? Do you get chest tightness? Do you get night cough? And these are not relieved. So all these things will hint towards a bronchial asthma or a hyperreactive airway type of thing. And this history is important because nowadays every city in India is polluted. Lot of construction going on, dust is there. Most of the patients will have a hyperreactive airway. With this comes the nasal polyp or the chronic rhinosinusitis, and most of the time, all of them will have a very poor quality of life. That is what the ARIA guidelines mentions. And you have to ask, especially about sleep and the work pattern. In adults, it's very easy to understand how is the sleep and how much is the quality of life, because a patient can tell you, I am not attending my office, I have to apply for leave again and again. But it's the kids where you have to be very careful. Are they sleeping well? Because if they don't sleep well, the growth hormone is not released, the REM is not there, and so on, the whole scenario. Also in kids, the absenteeism in school is very high, and there will be a scholastic backwardness. The kid is not concentrating in the class, and he is not taking part in the outdoor games, basically physical activity. Because These are the kids who will be very happy with the gadgets and all. So all these things can be a part of allergic rhinitis. And they are basically come into the umbrella of Th2 inflammatory pathway. This is a picture where most of the ENT surgeon will be seeing a patient of allergic rhinitis with recurrent nasal polyps, and it becomes a very irritating thing. You have done your best job as a surgeon and this patient comes again and again with a polyp. What to do then? So what is CRS? Basically, it is one of the presence of two things which you can see here. There has to be a nasal obstruction along with a facial pain, pressure, and reduction of smell. So smell is a very important part of your CRS diagnosis. And if it is more than 12 weeks, then you label it as a chronic sinusitis. Now, this is the pathophysiology. If you see the upper half, if a person has a normal sinus mucosa, now whatever trauma we get on the mucosa, any inflammation, viral infection, bacterial infection, pollution, all those things, if your immunity is good and your genes are good, it undergoes a resolution and there is no problem. But what happens if you have a history of atopy? That means there is someone in the family. Rupali just said one parent, you will get 40% allergies. Both the parents' allergy will be more than 60% and so. So in such cases, there is some problem in the genetic environment. Also, there is a epithelial dysfunction. Now, whichever allergies you will see, whether it is a nose allergy or a skin allergy, there is a disruption of the epithelial layer, and that is how the whole process starts. Then you have all the microbiomes, the viruses and the bacteria getting into it, and Staph aureus is the commonest one. There is problem of the repair mechanism, and that is how the patient is getting CRS again and again, that is chronic sinusitis. And these are the questions very important for all the PGs who are discussing something important, I guess. Please listen to it. These are good questions. You will get it in your theory also as well as your practical also. So in CRS, two things one has to understand. One is a phenotype and one is the endotype. In phenotype, we have two types, CRS with nasal polyp and without nasal polyp. This is a variety which you see most of the time. And what we have is the eosinophilic mucin variety and the AFRS. Post-COVID, we have seen a lot of AFRS. There is a small component of the aspirin exaggerated disease also. And other CRS component, which has something to do with your immunity, like cystic fibrosis and so on. These are the endotypes and phenotypes in a one slide together. If you see the lower part, this is a Th1 variety where your neutrophils are more important. If you see a patient with lot of mucus and the blocker variety, and on histopath you see neutrophils, it is Th1. But what in allergy we are more concerned with the Th2 pathway, where allergic rhinitis and CRS with nasal polyp will come most of the time. And this here you will see eosinophils are very, very predominant. And this, when you see a histopathology report, after you send it to a path lab after the surgery, you will see that the eosinophils are very high. That is a Th2 variety. How do you understand it's a Th2 inflammation? Because there will be high levels of eosinophils. This you can find in the tissue, that is the nasal polyp. You can also see a peripheral eosinophilia when you do a simple CBC. Also, the total Ig levels will be very high. Rest of the investigation, whatever book says, is not practical possible, especially in a country like India. So how do you approach a patient with this recurrent nasal polyp? Most of the time, in your majority of the patients, the treatment is surgery. 90 to 95% of your patients will undergo surgery for nasal polyps, and that is the best treatment. But many of the time they recur. So what do you do? Obviously, oral steroid. That is the option we have. But as we all know, oral steroids are the most potent anti-allergic and anti-inflammatory. That's why any inflammation in the body, for autoimmune condition, everyone gives steroids. But whatever you do, long-term steroids are not good. You get a lot of infections, cataract, gastric ulcers, and so on. It's not an advisable thing. Then what do you do for patients who come with these symptoms and again? You go for something called as the biologicals, which are the disease modulator. And in minority of the patients, what can you do? And what are these patients? If there is a contraindication to the surgery, patient had any other IG diseases like asthma, and where the patient has said, no, I don't want surgery. This part is very important nowadays in practice. Once a patient had a surgery, if there is a recurrent polyp, he wants an option of medical management. You have to give that option, and those options are the biologicals. So biologicals and the allergen immunotherapy are the game changer now in any of the nasal allergies, in other allergies also, but we'll concentrate here. So this is the chart Rupali just showed. These are the latest euphoria guidelines. I want you to concentrate only on the two aspects. It says if you have a severe allergic rhinitis or there is a failure of previous treatment, that is recurrent nasal polyps we are talking, the answer is allergen immunotherapy to this patient. You can also give oral steroid surgery and add-on therapies, which are the biological. But just look at the last point. If you want a sustained long-term effect or a cure of allergic rhinitis, the answer is only allergen immunotherapy, especially to dust mite and pollen. So what is this immunotherapy that everyone is talking about, that it changes the whole disease? When you give pharmacotherapy to the patient, whether it is a nasal spray, antihistaminic, steroids, whatever, you're only treating the symptoms of the patient. And the symptoms will be better till the time the medicines are working. Once the effect of medicine goes away, 12 hours, 24 hours, again the symptoms happen, again you take the medicine. This is true for maximum of the disease, whether it is diabetes, blood pressure, heart disease. You have to take those medicine again and again so that the symptoms are controlled. But once you give immunotherapy, the concept here is like any other vaccine. You identify the allergen and you desensitize the patient to that allergen. So it's a natural treatment. If it is given in the right form, there are no side effects to this treatment also. So commonest way of giving allergen immunotherapy is the injection, and now we have the liquid and the tablets also available. And this is a disease modulating treatment. There are very few treatment on this earth which modulates the whole disease. Vaccination is one of them. You inject the same biological agent, and that is how the patient overcomes the symptoms of that disease. And this will change your Th2 inflammation, which is an allergic inflammation, to a non-allergic one or a normal one, or what is called as the Th1 inflammation. So how do you make the patient understand? This is not a good example of what is going on now in India, but this is one of the best examples I was giving to my patient for so many years. And now let us understand. So when the patient will ask you, see, my tips are very practical. This I have learned only by talking to my patient. No one has taught me this, but I'm teaching you this ready-made material. Use it for your patients. So patient will ask, I am allergic to dust mite and you are giving me dust mite. How my body will accept it? I will start reacting. The answer is yes. You will react if I'm giving the dust mite in high doses. So how do you explain it? Suppose this is a border and you have all your soldiers over there. So these are the IgE antibodies in the body. Now mind it, when you do the blood test, Rupali was talking about serum specific Ig. So every one allergen will have a specific IgE antibody to it. So how we have colors in the school, color house. So one will be yellow color, red, green. So every allergen will have a very specific Ig antibody. So once the allergen enters there, they all will attack. When they attack, there is a release of histamine and all the mediators, inflammatory markers, and that is how you get reaction, whether it is allergic rhinitis, asthma, urticaria, and so on. Now what do we do? You must have watched these movies, right? Spy movies, always there. When you send your spy to the into the other enemy country, they will go there, be friendly with them, they will stay in their house, and at night when everyone is sleeping, they will murder them, and that is how the whole war is won. This is what the allergen immunotherapy does. You are putting the same allergen in very small quantities, in drops or the tablets or whichever form, and as you are escalating the dose, the body actually does not realize, and it starts producing IgG against those allergens, and that is how a desensitization or a tolerance to that allergen develops. So if I'm giving my immunotherapy to dust mite, the patient will get benefit only from the dust mite. He will not get benefit from the cat allergen. That's why it is called as a best example of a precision personalized medicine. So this is what I was saying. AIT you can give in any form, but what it will do, it will decrease your symptoms. Because the symptoms have decreased, you can taper off the medication of the patient, which we see in the YAKI guidelines, the step up and the step down process. And this will preserve. And that is how the quality of life of the patient decreases. Now, one thing about the second generation antihistaminic, whatever anyone says, pharma, these, that, if you are taking antihistaminics on a long term, you do get some type of brain side effects. Why I say that? Because you will find these patients will say, I take it, I sleep, but next day I'm not feeling good. I just have some brain fog. I am not able to concentrate well. My work, the proficiency is decreasing. All these small things, if you realize, you stop the antihistaminic, they're doing very well. And one word of caution for Montelukast, now it is banned by the US FDA. So whenever you want to use Montelukast, please do it very carefully. So this is why I was saying that immunotherapy is a unique and unmatched model of precision medicine. It is personalized as per the skin prick test of each patient. No two patients will have the same immunotherapy formula. How a tailor makes your clothes customized to your size, same way we do for immunotherapy also, depending whatever the allergen patient has come positive on the skin prick test. And this is one of the best treatment for your patients, because these are not medicines. Again, I'm saying that's why they don't have any side effects. So going back to the pathway and how do we affect it? So a Th2 inflammation happens, as I was saying, if there is a disruption of this epithelium, all the allergens and parasite goes into it, it activates the inflammatory pathway. And when this happens, the IL-4, 5, 13s get activated, the Ig level are increased, and you see all the effect. So depending on this, the biologicals were made, which are natural products from living organism, and they have changed the whole scenario now. What are the biologicals which are approved for CRS with nasal polyps? We have omalizumab, which is the prototype of all. Now we have dupilumab, benralizumab, mepolizumab, and so on. So the other twos are the IL-5, and dupilumab is IL-4 and 13. So when you give dupilumab, now depending what the patient has, because we are concentrating only on the nose allergies, I will just briefly touch it. Dupilumab works against IL-4 and 13, and that's why it has effects on eosinophil, mast cells, basophils, and so on. Whereas omalizumab is actually an anti-IgE. Now, what does this anti-Ig do? It is a humanized monoclonal antibody. So this video you can see, these are the circulating Ig antibodies in the blood. So when you do a blood test, this is what you detect. And now these Ig antibodies are present on the mast cells. This allergen has come into it. It has attached here. There is degranulation of the mast cells, and this histamine and the mediators are released, and you get all the reactions. Now this is omalizumab, the green one. So what this does, it will bind to all the free circulating Ig levels. And because it has bounded there, they are not available for a reaction. So when there is no reaction, there is no symptoms. And that is how eventually the body will stop producing this Ig. This will take some few weeks to few months. And now if there are no Ig, or the Ig has decreased, you will not get a reaction. This is what omalizumab does. So how do you explain it to your patient? Many of the time the patient thinks if you give omalizumab injection, the Ig level will come to normal. That is not what happens, because now one IgE, one omalizumab will bind to your IgE. Now they will make 1 + 1 = 2. But this is an inactive form. Because it is an inactive form, the reaction does not happen. And how do you explain it to your patient? Suppose there is a thief in your house and it is doing all type of robbery here and then running around, and it's a chaos. You all know what happened to Saif Ali Khan, something of that sort. What do? You catch the thief and you tie the hands and legs and put him in the corner of a room. Once you have done that, the thief is there in the house, but he is not going to damage your property or rob you. That is what this complex does. The complex is present in the body. If you do blood test, the Ig level will be double now, because it is Ig with omalizumab. So 1 + 1 becomes 2, but it is an inactive form. Many of the time when you give omalizumab, the patient is so excited, let me see what happens to my IgE. He will do a blood test without your knowledge, and now the Ig has doubled, and he will come and question you. I am better, but how my IG is double. So you should know how to explain it to the patient. This is one of the most important slides. How do you decide to give biological? These are EPOS 2020 guidelines, easily available on the net. And if a patient already had a polyp surgery, you need 3 criteria to decide to give biological. The first criteria is a tissue eosinophilia. If it is more than 10 high power field. What does this mean to a ENT surgeon? Suppose you have taken a patient of nasal polyps and you take biopsy and you send it for histopath. In the few years back, they would say mucin positive eosinophils plus plus. So every time you send a biopsy, you have to tell your pathologist, please tell me what is the eosinophil number per high power field. That will tell you whether it is a tissue eosinophilia. Also, you can see this eosinophil in the blood where it is more than 250, that is the absolute eosinophilic count. Now, most of these patients will have other IG comorbidities also, and they may be requiring steroids. So if the patient is using steroids of more than 2 courses per year or for more than 3 months on a long-term basis, the dependency on the steroid is very high. Other criteria is a SNOT 22 we were talking. If the score is more than 40, and here is what the anosmia comes. If your patient has anosmia, this is one of the criteria of avoiding it. And the last and not the least is if the patient has any comorbid condition like asthma, you can use it. These are the euphoria guidelines. At least 3 of the criteria you have to have if the patient had history of surgery. But if there is no surgery, you need 4 criteria for the same. Now, how do you assess whether patient has become better or not? You assess by evaluating 5 criteria, whether the polyp size has decreased, the need for steroids have decreased, the quality of life has increased, smell has increased, and the comorbidities have decreased. If all of these are happening in 16 weeks, you can continue with the treatment. If not, you stop the treatment. This is the omalizumab study for nasal polyps done by Philip Gaviot, a very good friend. And he said that omalizumab works wonders for most of them. How do you decide how much omalizumab to give? It depends on the IgE levels and the weight of the patient, and accordingly we decide on the dose. Most of the time, how do you decide which biologicals to give? Omalizumab you can use for allergic rhinitis, asthma, CRS with nasal polyp, urticaria, and so on. But dupilumab, because it is a IL-4 and IL-13 antibody, you can use it for asthma, atopic dermatitis, and CRS with nasal polyp. It works wonder for all of them. Unfortunately, it has been launched, but it is still not available, and let's see what happens. You can use both of them as an adjunct to many of the diseases like food allergy, food anaphylaxis. If you want to give a cluster immunotherapy where you inject large doses very quickly and you don't want the body to react, you can give omalizumab. These are very important. See, initially it was an era of expert medicine. One person who is best in the field, he said something and the whole crowd is following it. Then came evidence-based medicine, where if you know the pyramid of EBM medicine, the RCTs and the metaclinical trials, all those things were important. Then came the real world evidence. We are in the era of real world evidence and precision medicine. So these are the 4 P's of precision medicine. I have put it here. Please take a photo if you want. And these are on EPOS 2020 guidelines. Here you have to take care of what the patient wants. Everywhere I am saying the same thing. Gone are the days where one formula was okay for all the patients. You have to speak to the patient, understand the phenotype, endotype, what disease pattern it is, explain the patient. Many of the time the patient comes that I don't want even the first surgery. So how do you explain it? What is surgery versus biological? What are the endotypes? All these things you should be aware of in today's era. This is a brief summary of how to choose the biological, the patient, and how do you assess the treatment response. I have already spoken on all of them. Just a recent thing, now we will be getting biologicals for CRS without nasal polyps also. And this is the future where we will get anti-IL-25, 33. But we have at least a decade for all these things to come in India. I have just put it for theory purpose. Again, I spoke about the NSAID exaggerated respiratory disease. If you have a patient of allergic rhinitis, asthma, they take NSAIDs and the disease gets worse. You must be knowing about the Samter's triad. It is one of the very commonest MCQs for ENT. Then you can make a diagnosis of NERD based on the challenge test. We routinely don't do it, but it is important for you to know. This is one of the very commonest phenotypes which was very common during the COVID era, that is allergic fungal rhinosinusitis. And there are 3 varieties in this which we have understood now. If the patient has a good immunity, that is, if the patient is hypersensitive to this fungus, you get AFRS. If the patient is immunocompetent, you get a fungal ball. You must all have seen the fungal ball during the nasal surgery, I'm sure. But if there is an immunosuppressive host, you get an invasive fungal sinusitis. So these were the latest updates in theories. Now let us quickly see whether we can convert it into practical use. Otherwise, there is no point of me taking a lecture. Whenever you come, Rupali also said history is the most important. 80 to 90% of the time, you will diagnose an allergic rhinitis patient based on the history only. You don't need to do anything. But how to prove whether the patient has allergies? Do a skin prick test. If the patient has one airway, one disease, that is, he has some amount of wheezing, asthma, please do a spirometry or a peak flow meter. If you don't know how to do it, we have our pulmonologist colleagues, send it to them. As an ENT surgeon, you can do a nasal endoscopy, CT scan, and so on. Most of the time in my practice, patient comes to me with a CBC and IgE. A total Ig level is not mandatory to diagnose allergic rhinitis. But if whenever you do a histopathologist, please talk to your pathologist and explain them that we need a eosinophilic count for the patient. That is how you will put him in that TH2 criteria. This is a very short, quick video of a recurrent nasal polyp. Here you can see this is a left side cavity. It is well healed. You can see the maxillary sinus opening over there. And it's very nice, open and patent. And as Dr. Mohanty was saying, the purpose of FES is a good ventilation and drainage to the cavity, and also to make space for your medicines to be delivered. Now this is on the right side. And you can see this is the polyp and all the secretions, this suction, now the secretions which are coming in the suction, these are the mucin. And just see how thick they are. This is the typical allergen mucin. How many times you do the surgery for such patient, You have done a wonderful work, but still they come. If you do a CT scan, another new questions for the residents, gold medal answer. If you see, this is something called as a central compartment atopic disease. CCAD is the new terminology. And you will see all the haziness is in the center compartment and the peripheral sinuses are escaped this disease. The reason being, when a patient with allergy takes a breath and there is an air current, it goes through the nose and the floor and all those physiology which we know, the maximum allergen are hitting this center part, and that's why all the inflammation is in the central part. That's why it is called as central compartment atopic disease. But if you see this slide, these are polyps, recurrent polyp, but they are not CCAD. Mostly this is a TH1 variety, but not a TH2 type. So you have to understand whether it is TH1 or 2. That is how you will decide on the treatment and the success of this. Now quickly some cases. Young female, already operated 4 times. She was referred to me for the 5th time. Positive on dust mite pollen. Ig level was almost 900. What did we do? We gave her a allergen immunotherapy to dust mite and omalizumab. And you can see within 4 months, the whole sinuses are clear. Another case of young female operated 3 times. The 3rd time it was AFRS. And you can see the successive picture from 1st month to 3rd month, the polyp size has decreased a lot. This is another ENT surgeon with CRS with nasal polyp, AFRS positive, again on treatment and doing good. So what you have to understand, that's what I was saying, if we have non-ENT doctors also here or ENT doctors, when we are ENT surgeons, the patient comes to us, we see only the nose of the patient. But many of the time, it's not the nose which walks into your clinic. It's the whole patient who is walking into your clinic. You all have done your MBBS. You have a knowledge of all the other subjects. Most of the time, these patients will have a lot of other issues also, that is asthma, urticaria, food allergy, drug allergy, and they come into the preview of the multiple allergy syndrome. So as a doctor, you should be aware of this, and just few Clinical cases, how do we treat them? This, you can see there is some atopic dermatitis on that side, the neck and the forehead and all. This patient, all the patients which I am showing, we were treating them for some allergic rhinitis, asthma, something with omalizumab we were treating. But you will see it has benefited the other parts of the body also. So as I say, we are lucky that the body has not read medical books. Because we read books, sometimes we just think inside the box. We never think outside the box. But when you start treating the patient, later on your patient becomes your best teachers. And if you have a keen observation of what is happening, it should be a passion for that work and you will be able to understand a lot about the disease. Who is this? Sonu Nigam. So if you ever trolled him or whatever, a few years back he had a very bad reaction to food allergy, and this was because of the seafood he had. And luckily he said, I was close to a hospital, I was given adrenaline and I was saved. So patient can have history of some food allergy or anaphylaxis. Patient can present with urticaria, angioedema. I was just discussing urticaria with one of the person over here while coming, and all these things are very disturbing to the patient. So if you understand this, you know where to refer to the patient so that they get the best treatment. Now with immunotherapy also you can give biologicals, because they are basically a safety net. You're going into a war, you know you can be hit by a bullet anytime, please wear a armor. This armor is what biologicals gives to you. So in our center, we have given more than 1,200 injections of omalizumab. I think this is one of the largest studies in India. And we have given it for multiple IG conditions, and the results are really promising. One thing, please be aware, I know this is a Gen Z, Zen millennium, what all is going on, I don't know which generation is going on. Please talk to your patient. Medicine, you can't learn on YouTube or webinars. It is good for theory, but what your bedside will teach you, what your bedside rounds will teach you, none of the webinars or YouTube are going to teach you. They may fetch you marks, but you will not be a good doctor. And mind me, with this AI thing coming, where there are very few fields who will be saved. You know, one will be medicine. AI is important in medicine, no doubt. Other will be HR and so on. So please talk to your patient, understand the disease, take the patient as a whole, have a holistic approach, make a treatment plan, make some YouTube videos. That's very good to, you know, disperse your knowledge. Whether it is doctor, patient, it's one of the best media nowadays. It can make you or break you. And one more thing, whenever you give nasal spray to the patient, or if you're an allergy specialist and you're giving inhalers to your patient, please check the technique. I have seen so many ways of seeing the technique. I'm sure if there is a pulmonologist, they would have seen so many techniques, the way patient uses the inhaler or the rota caps. They will even break the rota cap and take the powder like this. What all we have not seen. So whenever a patient says of allergic rhinitis that I am taking the spray, it is not benefiting you, 90% of the time it should benefit. And if the patient is saying that, ask the patient to show you the technique. I had a patient who came to me that I'm allergic to the nasal spray. I said, why? I put it in my nose and I start sneezing. I said, show it to me. She just touched the septum. Obviously, when you're touching the septum or any mucosa, the sneeze reflex will be activated and then you start sneezing. And she assumed that she's allergic to the nasal spray. So please talk to your patient. Always ask them to carry the medicine, show the technique and take it forward. Stress is a very integral part of everyone's life now, similar to mobile, laptop, social media. If you are stressed, most of your allergies will worsen with stress, especially the autoimmune conditions. So you should understand this whenever you talk to your patients, especially the skin allergy or the hives or urticaria. And all autoimmune condition will worsen with stress. So how do you enhance your immunity? Just a brief thing. Please eat healthy. The more colorful things. Colorful means the natural colorful things, not like that chili chicken we had, which was full of red color, not that color. Have most healthy fruits, vegetables. They give immunity booster. Please sleep well. Stop seeing Instagram at night. Stop scrolling. It is such an addictive thing. The more you sleep well, your immunity becomes better. Your allergies do decrease. Exercise, no, there's no replacement of exercise. That's the best addiction you can have. And as Dr. Mohiti, I take it as a compliment, whatever he said in the beginning. I don't mind people appreciating my weight loss. I still spend 2 hours in the gym. no Ozempic, no bariatric, nothing. So please do that. A good exercise will increase your immunity, will give you a good shape to the body. And last but not the least, please have a digital detox. Start meeting people, friends, relatives. Get away from your digital screen. If you're not bored, I will just tell you what is the real world evidence at my center now. Because I'm boosting so much about everything, I should tell you the results also. So we have seen more than 3,000 patients now, 1,100 are on immunotherapy. And believe me, if your patient is allergic rhinitis, if your allergen immunotherapy, the selection, quality, and all those things are good, 90% of the time you can take your patient off antihistaminic and the nasal spray within 3 months. And the way the patient comes to you, when you see a post-op patient and the patient says, Doctor, I'm so happy we saw a stapes patient, the happiness on the face gives you a kick. All doctors, all surgeons gets a kick when the patient comes back happy to them after the surgery saying, I'm doing so good. Same kick you get when you find a patient coming and saying, I've stopped my nasal spray, I'm so happy. So that is important as a doctor. Now, some of the, because I started doing lot of allergy thing, we have presented our data in various part of the world. Something we did about food allergy at the Asia Pacific conference, about omalizumab in the American conference. But one of the two observation which I think I thought out of the box, which I would like to present here, was this paper when we were giving immunotherapy along with biologicals to all the patient of AR with CRS with nasal polyp, we realized that somewhere the need for biologicals were decreasing. So maybe that allergen immunotherapy, because it modifies the whole disease, actually decreases the need for biologicals. And this was the paper which I presented last year in the European conference. And this is first of its kind paper in the whole world. No one has done such a observational study anywhere regarding AR with CRS with nasal polyp. So whatever you give to the patient of AR, whether it is a pharmacotherapy or biologicals, they all are short term. They give relief to the patient, no doubt, but it is on a continuous basis. Whereas allergen immunotherapy is like your champion from Turkey, one revolver, one bullet, and bang, you shoot in the bull's eye. That is what allergen immunotherapy does. It modulates the whole disease for the allergies. One more very interesting paper, which I'm very proud to present as an Indian, is when I was into my allergy journey, I realized we never have any peanut allergy in Maharashtra. If you know, or in fact, the south of India, we eat so much of peanut. We have it in our poha, in dal, in sambar. We have peanut chikki. Everywhere peanut is there, but we never die of peanut, which is so common in US and UK scenario. You know, even they can smell peanut and they can die. There are so many cases of peanut allergy. For this, I received a gold medal. And what was my thought process was, if you know anything about allergy, the sensitization is happening through the skin. Okay. So even if the kid who is an infant now, he has never had peanut, he smells it or eats it and he goes into a reaction. I'm taking pause because I'm getting disturbed by a few people talking at the back. So now, once the skin, if it is not normal, there is peanut in the air and the sensitization is happening through the skin. That is how a food allergy sensitization happens. It never happens that you eat a peanut and you get sensitized and then you get an anaphylaxis. So my theory was, in India, most of us know about oil massage in infancy. I'm sure all of us mostly had an oil massage when they were infant. So this is a very old age tradition. When we put oil on the body, there is a good lipid barrier on the skin. Now, because of this lipid barrier, whatever aeroallergens are present in the air, it doesn't enter into your skin and doesn't cause any sensitization. Because this is not happening, maybe the food allergy was not happening. So this was a out of box thinking retrospectively. That's why maybe we Indians don't have so much of food allergy. And now why we are seeing so much of food allergy? Because the young generation is not doing it. But this is true only when you have a normal skin. If your skin is abraded, then if you rub it, you're causing more harm to the skin. So we don't want that. And when we presented this in the World Allergy Organization, there was an Indian doctor in the crowd who was now in US, but he said even now when I come to India once in a year, I buy mustard oil. He was from Calcutta, and still every Sunday to Sunday I am doing oil massage before my bath, and I am really very healthy. And my grandchild, who doesn't have allergy genes, still has food allergy because he was born in the US, and this tradition was not done. So somewhere I feel our Indian culture, this is one part of our culture. There are so many examples in our Indian culture. I feel our Indian culture is very allergy protective. And so instead of copying the Western world, we should Easternize the Western world into following our culture. So a patient who comes with allergic rhinitis can have lot of other allergies like asthma, food allergy, skin allergy, drug allergy, vaccine allergy. There is a huge sex allergy talk also, which I gave to a sexologist conference. But all of them basically are a Pandora box. A patient presenting with allergy can be a huge Pandora box. Only one disclaimer, we don't treat spouse allergy. So that's all for now. Thank you for your patient listening. And if anyone wants to do a hands-on fellowship in allergy sciences, you can approach me. Thank you once and for all.
Thank you, ma'am, for the deeply informative session. Now we will move on to a brief question and answer session.
You, if others are there to ask questions, but personally, what I would want is to know with the new guidelines with AIT, with or without biologics, is it only for recurrent polyposis or a primary nascent polyposis also you can start off? Just wanted to, you can go there. Then the next, after you answer, then I'll ask the next one.
So, sir, if you can prove it is a Th2 inflammatory pathway, to which allergic rhinitis is, and you have to prove that it is skin test, blood test, whatever other criteria we mentioned. It works wonders. It has a 1A level of evidence for allergic rhinitis. But if this allergic rhinitis has a comorbidity with CRS with nasal polyp is a culprit, and you can prove it is a Th2, then yes, it will work for that also. So that polyp 100% will not just go away with immunotherapy because there are many other factors to that polyp. So, but yes, it will definitely decrease the chances of that. So it should be given.
And any specific experience of yours about the distortion in the smells part of it, the olfaction part?
Yeah. So most of the CRS with nasal polyp will have anosmia. That's why in that one slide of quality of life, I said that smell has to be taken care of. If you give biologicals, they regain those smells because I think what surgery can't do to that olfactory area, these do because it's a systemic disease. When you remove it by surgery, you're debulking the disease. There are many microscopic inflammatory parts which we can't handle with surgery. I think that is where the biological and AIT helps. The region that is cleared of all these interleukins and the inflammatory reagents, and that is how the patient starts smelling. The results are superb with the smell. That is, it is one of the important criteria in decision making.
And the last airway, when we talk about all these aspects of pharmacotherapy, many patients are also having a hyperreactive airway when they approach you. Does that also get a little benefit after that?
So there are many studies which talks about the role of allergen immunotherapy in allergic asthma. Now there are many phenotypes of asthma. I am talking only about the allergic asthma. If you do this, the nose becomes better. So the trigger from the nose does not happen. The airway does not react. This is one thing. Whatever is the capacity of the lungs, it will not worsen. Either it will increase or it will remain the same. The need for ICS or the doses of the ICS decreases, need for oral corticosteroid decreases. Most of the time now these patients will not be hospitalized. That means the acute attack of asthma. Exacerbations decreases. So these are very good criteria. And there are so many studies now which say that AIT improves the mild to moderate asthma or not. That's why now this immunotherapy to dust mite is in the GINA guidelines also. Right from the second stage to the fourth stage, they say that if your dust mites are positive, please give immunotherapy to dust mite.
And this,
GINA guidelines are the global network of asthma.
and nowadays, with the plethora of information that is available in the World Wide Web, many patients come and ask us, we have done a allergy test, a skin test. They've done some 14 allergens. What is the maximum? Like one person from Dubai came and told me that I've done 136 allergens. I don't know what's the highest in the world. So
What happens, the more you are experienced, and you get shoot at one bullet was enough. So if you are a novice, you need a AK-47 and multiple bullets to target one thing. But the more experienced you become, you start with 100, but the more understanding of allergy happens, and then you will go on decreasing the need. So how do we decide how many allergens to do? When we take a history, if it is only allergic rhinitis, we need to do only aeroallergens. What are these aeroallergens? 3 dust mites, few pollens from that region wherever the patient comes from, some pet dander, pigeon feathers, mold, and so on. So maximum 20 to 25 allergens. But if the patient has food allergy also, then you decide what to do. So nowadays there are, as in every field, we have a lot of quackery going on. In this allergy testing also, we have some technician will go put 200 drops also. They will do it. There is some wheel and flare, whatever coming up, they will label the patient as allergy. We have seen so many patients who comes with such report, multiple foods are positive. There's something called a dermatographism where the skin will react and all. And the patient has stopped eating those nutritious food, though he is not allergic to it. When you get a reaction on the skin prick test, it means it is a sensitization. That means the body identifies this allergen, there is a specific IG to it, and you are seeing a reaction. But there, the time the patient starts reacting to it and shows you clinical symptoms, that is allergy. So from sensitization to allergy, it can be a gap of few months to few years. If the patient is not allergic, we do not treat or we do not ask the patient to stop it. That is where the second history comes into picture. After doing a skin prick test, whatever has come positive, you understand, talk to the patient again, and you correlate your history with whatever has come positive. That's where the knowledge of allergy is important. Otherwise, doing a skin prick test is very easy. There is no art to doing the skin prick test, but how to interpret the test is important.
always.
Like for every doctor, we say when you put a stethoscope, everyone will put it between the 2 ears, but what I will hear, what you will hear, what they will hear is different.
Again,
What is between the two?
Yeah, the taste of the pudding concept. Anybody else, Ram? Anything specific from your side? There's some senior doctors around. They're pretty experienced.
Thank you, madam. This is from the question is for actually for the previous speaker maybe. How is CDS done? No, Dr. Rupali's CDS.
What is CDS?
CRD, yeah? Sorry, CRD, yes.
So CRD is basically component resolved diagnostic test. What does it mean? One protein will be split into multiple proteins.
Like that I understood. How is it done? From blood?
It's a blood test.
Okay.
You take blood test. Now there are 2 types in CRD. One is a single plex where you test only that one protein. Like you want, what are you, sir? What is the specialty?
No, ENT surgery. Yeah.
Okay. So you have allergic rhinitis patient with dust mites and all, and you will do only for dust mites. But suppose the patient goes to a pediatrician, he would like to do milk, egg, depending on the history. So this is called as a single plex when you are doing only one or two subjects. Then we have a multiplex where basically you take the blood sample and it will detect 295 allergens on that one test. So depending what you want, you have to do it. But this is very basic. Nowadays, every allergy specialist will ask for it.
So there are 2 things. One is in the laboratory, you get all the serum specific IgE that you get.
Okay.
Second
So
is
yeah. When you do a serum specific IG, you will get the number.
Yeah, number, yes. 0.5, 0.15, yes.
Depending on the lab. But there, suppose you are doing dust mite. So you will get D-farinate, D-10 versus bromia. But when I do this, now there are 40 protein components of the dust mite itself. So we have DERP1, DERP2, DERP1, DERP, then bromia. You will get a split of all of this. Now why this becomes in today's era, when you give allergen immunotherapy, there are only few proteins which are called as a major allergen. If that is positive, you give immunotherapy, the patient will get good result. Now there are many minor determinants. which you don't know on the skin prick test. Here you will get positive, but there you will not get it. So whether to give that patient immunotherapy or not is important. Many times you have started immunotherapy and the patient is not better and you want to know the reason why. Then you do a CRD. So CRD is not a replacement for skin prick test. Skin prick test is still the gold standard diagnostic method throughout the world. That slide which Rupali said, all the organizations say do skin prick test. And there's one more reason I will say to a ENT surgeon why this is important. When you are doing dust mite is common and same throughout the world. What about pollens? From Maharashtra, pollen will be different. Tamil Nadu pollen will be different. Himalaya pollen will be different. When a patient comes to you, you want to check the pollen where he is staying. When you do a blood test, they have all the European and American pollen. Why should I do the testing when the patient is in India? I should do the Indian pollen. That will not only skin prick test. Because these pollens are harvested, purified, extracted, and all that process, and you get those drops. So I think that's why that SPT is better. So this is for allergic rhinitis. But if a patient has food allergy, in SPT panel we have the whole spices of India: turmeric, dhania, coriander. You think and you will have it in the product, but you don't get it in the blood form. So why do that blood? It is costly also. SPT is cheap, but you should know what is the science behind it. Everyone can't do a skin prick test, as I gave the example of.
Yeah, I understand. Next question. What is the cost of the somalizumab therapy?
So, no, I will tell you in detail about omalizumab.
How to give and what is the first dose? How to give?
I will explain you everything. Now, as an ENT, should I explain you or with asthma, with urticaria, everything is different answer. So I will try to give answer accordingly. So omalizumab was originally named as Xolair from Novartis. That 150 milligram pre-filled syringe or injection, that was almost 33,000. Then they withdrew from the market, India and Chalani, and now we have biosimilars. So we have two biosimilars. One is Omalizumab, which is made by Reliance Life Sciences, and the other is Enzumab, which is from Cipla. So each is around 13,000 and 12,000. You get it at a discounted rate. So depending what is the IG level of the patient, I showed one slide here that is easily available on the net. If you go on the website, what is the IG level or what is the weight of the patient, you decide how to give. So whether it is allergic rhinitis, nasal polyps, and asthma, you will have a dose depending on the IG and the weight. In urticaria, whatever may be the weight of the patient or IG level, you have to give 300 milligrams every 2 to 4 weeks. That is not dependent on the IG level. That's the only difference. I hope I have said all the systems. No asthma, urticaria.
No, 2 doses per week. Everything the same thing.
The thing is, even if your one dose is 150 milligrams, right? If you have to give minimum 300, so you imagine 10,000, 20,000 treatment per month, every patient can't afford. So that affordability is also important. And whenever you want to give it, you please tell the patient this is temporary. Huh? They think one injection and that it is not that way. That's why that one slide where I said pharmacotherapy, biologicals, both are temporary. You give it, they are better. You stop it, it doesn't become better. See, that is how I came up with that paper. Whenever I was giving biologic, I had 21 patients of recurrent nasal polyps. Whenever I was giving biologicals for 4 months and then we reassess. If they are on immunotherapy, they do very well. And the dose of biologicals decrease eventually. Then we started giving 2 injections in 1.5 months, then in 2 months, then 3 months, and still the polyps were not coming back. That is when we thought that maybe this is an AIT which is obviously giving benefit. Patient is not doing anything, he is not taking nasal spray, steroid, nothing. Then how come the biological need has increased? It's obviously the immunotherapy. Because it modifies the whole pathway only, na? It is called the disease modifying treatment. TH2 to TH1, that is where this need is given. That is how that paper was born.
One more question. How long do you give AIT?
So AIT, ideally AIT has to be given
3 years, 5 years?
3 to minimum. It has to be given from 3 to 5 years. Okay. But if you tell the patient at the first go, take AIT for 5 years, no one will come back to you. So how do you talk to the patient? I think that is what I was telling. Bedside things you can learn from YouTube or whichever medium. You have to tell the patient that we will be gradually increasing the dose. Now, for the body to understand, react, and do something, you will start seeing the result in 2 to 3 months. But when we do the escalation dose, that will take anywhere from 10 to 12 months. In that period, you will be better by at least 50%. But now to get more improvement and to have a disease modifying effect, you have to take it for 3 to 5 years. So don't say on the first go, you take it for 3 years. Let us start. Let us see how your body reacts, and then we will take a follow up. Why this 5 year is important? The scientific reason is, you know the polio drops, na?
Yes.
We give to kids. Why we say give it for 5 years? What is the reason of that 5 years? That's why I said that this drop is
To break that wild cycle, wild polio virus cycle.
Yeah, no. So the cycle gets broken very early in the stage. You have to change the memory cells. For any memory cells to change, it will take at least 5 years. That's why they give it for 5 years, and that's why we also say do it for 5 years. But maximum the evidence-based medicine throughout the world, they say 3 years is also good result. Now we have some tablets which have come up, they say only 3 years. But I have patients who are better with 5 years, and they are so happy. What happens eventually? You give it only once a month. So the patient is, I'm happy taking that drop once a month. If I'm away from all these symptoms of allergic rhinitis, I'm not on nasal spray tablets. Why I will not take? So there's no study. If you take it longer, what happens? No one knows, because it's a natural product. It's not a medicine. So if you take it long dose, it doesn't make any difference. And any allergy patient, you have to make them understand allergy has some genetics too. Your parents, someone had it, that's why you have it. Only the environment factor can't give you all this thing. When you give that, like suppose in COVID, one family with the same gene, one person just had a cold cough and the other person went on ventilator and died. What was the difference? The genes were the same family. It is the immunity. So once a patient has allergies, somewhere the genes are involved. How anyone will react to something, this is true for any disease, whether it is a cancer or whatever. So how that genes will change and how is your immunity? That's why those 4 slides of immune booster. These are the things which help you in your immunity. Nothing else will the what you eat, how you sleep, and exercise. These things affect your immunity. Nothing else. We can't change the polluted air, unfortunately, for the government or wherever we are staying. So you have to make the patient understand how much you will benefit. I don't know. I'm giving you a trial. Let us see what happens in 1 year. But if it is a pure allergic rhinitis patient with only that, 90% of the time he will be very, very good. He will bless you for that. And then we stop calling the patient for follow-up also. I see this patient only once in a year.
Ma'am, ma'am, have I come across any relapse of patients? Even if you give the 3 to 5 years of AIT, so once patient is symptom free for 2 to 3 years, have you come across any patients again, patients developing symptoms and all?
In clinical practice, what happens if the patient becomes better in 6 months, 8 months, then he will stop coming to you. He thinks, "Mera to ho gaya, abhi mere ko jaane." So the benefit of 6 months will stay for 6 months, 8 months, 10 months, depending on the patient to patient. But once they realize the symptoms are coming back, then they will come. So you can again start. But usually if it is more than 1 year, we do a skin prick test again to see whether there is some biosensitization. Because many of the time these patients are polyallergic or polysensitive. It's not only dust mite, they will have some coolers. Whether some new things have come up, then you will add it to the new formula of immunotherapy. So all these things you have to take into consideration. Not till 1 year back, we were doing everything with a skin prick test. There were many fallacies. Now we have CRD. So if a patient comes and he says, I'm not getting better, then we do a CRD to see what are the major component minor. But these are, if you're practicing allergy stuff, for basic stuff, a good immunotherapy to dust mite will work wonders.
Thank you.
But regarding that classification of TH2 to TH2 and TH1, should we always send a nasal polyp, or can the pathologist interpret from nasal mucin?
So there is a test with the nasal smear where you check for eosinophils. We also tried it initially in our practice, but I've seen with the smear you don't get good eosinophil counts. So if it is allergic rhinitis, no need to do anything. History itself is good enough. Skin prick test is good. Serum specific IG level is good, depending whatever you want to give the treatment. So we just do, when you get a tissue from the polyp, you send it to the histopathologist. For AR, we don't need a tissue eosinophil. That slide which I showed you was for recurrent nasal polyps. When to use biologicals. Otherwise, we don't need it.